Should I start, sir? Please. At the outset, I'd like to say I have no financial disclosures related to this presentation. So the question is, are we indeed smiling through our lenticule surgeries? Well, there have been certain issues like slower visual recovery, issues with centration and with toric alignment, surgical learning curve, and of course the ocular surface. So there have been various reasons why this has not been completely taken care of with existing lenticule platforms. However, this has been improving with all the later iterations of these machines. With this in mind, we wanted to think of our research question: can we overcome these challenges with new lenticule extraction platform? So this is a paper published by Dr. Mahipal's group. This uses the ELITA platform, which the highlights of this are a low energy treatment, minimal spot separation, which makes the ease of lenticule dissection much more, less keratocyte activation, and the biconvex lenticule shape that matches the anterior and posterior surfaces better and therefore causes less Bowman's distortions and less impact on quality of vision. The aim of our study was to analyze visual outcomes, quality of vision, and ocular surface in this new lenticule extraction procedure. We included 105 eyes with spheres less than 8 diopters and cylinders less than 4 diopters. We did the evaluation for dry eye on Schirmer's, TBUT, keratograph, and LipiView. We used our novel thermography device to look at the ocular surface, and we looked at aberrations using the eye trace system. We looked at our follow-up data for uncorrected and corrected visual acuity, aberrations, and contrast. So coming to our results, the efficacy and safety was found to be very good. Over 95% of patients in these 105 eyes achieved 20/20 or better. No eye lost more than 2 lines of vision. One eye had lost one line of vision because of an epithelial defect. The accuracy, as you can see in the plot of the spherical equivalent attempted versus achieved, was very good. Initial iteration showed a slight undercorrection, which was taken care of later on. In terms of the refractive accuracy, within 0.5 diopters on the autorefractometer, 66% of eyes achieved this, and within a diopter, 90% of eyes achieved that kind of accuracy. In terms of astigmatic corrections, we achieved an accuracy in greater than 75% within a half a diopter, and greater than 97% within a diopter of the attempted correction. In terms of faster visual recovery, we can see that there's a reasonably good visual recovery on day 1. What you can see is that it's about 0.1 in terms of Snellen equivalent, which is a pretty good visual acuity, which was maintained at day 7. We also looked at the percentage of eyes achieving 6.6. 82% on day 1 achieved 6.6, and 96% achieved 6.9. In terms of learning curve eyes, in the later eyes that we did, our uncorrected vision was almost 6.6 in majority of eyes on day 1. The Holiday EKR report shows a well-centered ablation in these, showing that you can center the treatment well. In terms of the aberrometry data, we showed no significant increase in aberrations, and a trend towards a decrease in the spherical aberration was noted in these eyes. As you can see, this is a representation from the eye trace system. In terms of contrast sensitivity, it was found to be, there was a slight reduction which was not statistically significant, and this was found to be better than the 40% at 10 cycles per degree, which is a good contrast maintained post-surgery. In terms of our dry eye data, the lipid layer thickness and non-contact TBUT also did not show any worsening. In fact, it seemed to be slightly better. And our thermography device, as you can see, we did a small study comparing lenticule and flap and found it to be better in the lenticule group. The limitations were larger sample sizes needed, long-term follow-up of data is needed, and assessing outcomes in low, moderate, and high myopes separately is needed. To conclude, with this new system, we have a faster visual recovery, toric alignment is possible, the ocular surface is well preserved, there's better centration with less aberration, and a shorter learning curve. Thank you.
Thank you, Dr. Rohit. If there is any question on, did you compare with any other method like SMILE and all, any, and found any difference?
We don't have two platforms. I can't directly compare with SMILE. So this is our initial data. We were one of the sites that did the limited markets release for this as well. So this is our initial data that we've got. I am trying to do a comparison between flap and this, but I don't have access to another lenticule platform to do a direct head-to-head comparison.
Any specific complications seen with this system, with this platform?
So the good thing is that suction loss is virtually non-existent in this platform. We did have cap tears, as you can have initially. So there was a initial, like I showed the learning curve, we did have 2 eyes with cap tears, one of which extended a little centrally as well. On the whole, dark spots were not noticed except in one eye where we had difficult dissection, which was quite prolonged. We didn't have any retained lenticules or anything like that, but there was a prolonged dissection time in that particular eye and a slower visual recovery.
Is there any study by Mahipal and all?
Sorry, sir? So I think Raghav is the best person. He's probably going to present that. But I think their data and ours is fairly similar. I think that's what you're going to present. But the visual acuities, I think the data published was on visual acuities, not on aberrations specifically. But there was good, there was quick recovery of vision in these eyes.
These are the machines used, I think, very recently. Mahipal started about a year back.
So I think Center for Sight, again, Raghav would be able to answer better, probably started the studies in 2019 or 2018.
And what about you?
We started this in 22 April, sir.
Okay.
Sorry, 23 April.
23 April.
Yeah.
Your post-op refraction was on, what you presented was on auto-ref
Yeah,
readings.
so that was on the auto-ref.
Was a subjective correlation also done in those cases?
So subjectively, I mean, a lot of those eyes were 6/6, but they were showing refractive error. So in fact, AR is not the best way to do it. That is a limitation. But then again, practically in refractive patients to do a subjective.
Did you try doing it with the retinoscopy?
We tried it in a few eyes initially, but again, doing that for a large subset is difficult.
Do you go for any little bit hypercorrection or
So
normal?
just now the nomogram provided automatically boosts a little bit, so it does do that on its own. We are not doing anything outside the nomogram which has been provided by the
so
company.
as per nomogram only?
Yes.
Okay.
Yes, sir.
Thank you very much.
The early results presented here were much better than the previous platforms. So do you think that is basically because of the biconvex nature of the lenticule, or there's some other role to play, or the lower energy which is...
So I think it's the lower energy probably. The aberration data may be related to the biconvex shape. Again, I think the NN group is doing stuff on the subbasal nerve plexus being better maintained. So I didn't have time to go through the thermography in detail, but for patients with neuropathic pain, we've looked at thermography, even in just normal patients, and we found that to correlate well with pain scores in patients who have normal Schirmer's and T-bar. And in this, we found a very good preservation of the ocular surface on that thermography device, along with the lipid layer and non-contact TBOT.
Thank you. Very good presentation.